Okay, other signs that a child is being sexually abused is this withdrawal from friends or activities, especially a sudden withdrawal. Changes in behavior that are can be rather dramatic, um, as you see on the slide here. Grades going way down, acting out at school, depression, anxiety. Tend to see this in kids where there's not a lot of supervision going on. And then if especially if the abuse is happening at school, then frequent absences are school and like you see, they don't want to go to school. They don't want to ride the bus. All right, other things, if the abuse is happening at home, they don't want to go home, so they'll leave school or they might run away. Um, we have a big problem, especially in the area of the Oakland airport. It's known as one of the highest sex trafficked underage prostitution areas in the country. And so most of the time what we see with those kids is they were sexually abused and that's why they ran away. And if you talk to them, they'll say things like, well, if I was going to have sex anyway, it might as well do it, you know, be able to be out of the house and not and have more control over it, which is really sad. Sudden attempts at suicide, usually just trying to escape the feelings. Fear of bathing and fear of strangers if it happened with a stranger. All right, I know these slides are hard to look at. Signs of sexual abuse, again, the reason I have to show this kind of thing is we want to make sure that if you see this kind of thing, you know what you're looking at. One of the things to know about is if you um, generally a child's vagina will show trauma if they've been penetrated, um, but with anal anal abuse, if they've been penetrated, one thing to be aware of is a full-grown man's penis can fit into a child's anus without necessarily causing any kind of trauma or injury. And so the reason why that's important to know is because if you're ever involved in one of these cases and they don't find injury in the child, but the child is saying that that happened, um, it is possible that it happened without any trauma to the anus. Um, and yeah, I'm not going to spend much time on this one, but you get the point. It's very bruising in the genital areas. Um, all right, and then so we have the questions sprinkled out through this PowerPoint because that's how they said it was the best way for you guys to learn. Um, I'm gonna let you look at this on your own and for just a second here so you can think about it. And the answer to this is the patient is in the honeymoon phase. All right, the effects of family violence on children. One of the things about children witnessing violence in the home is it develops their developing system, their brain, the neurotransmitters, especially something called cortisol, is going to be released more dramatically and chronically. And what happens is when that happens very young, it makes it where you release cortisol throughout your life that way. And so that's why we call these, you'll see on the next slide, we call these adverse childhood experiences. Now you remember glutamate, if you remember earlier, that's one of our neurotransmitters involved in memory. And Probably the reason why glutamate is secreted here is because when we're in danger and we're in trauma, it's very important, as an organism that we remember why. And so that's why glutamate. All right, so the adverse childhood experiences, and we'll talk about this a little bit more in the childhood disorders lecture. Um, these are all the things that you would think they are, and for adults, it puts you at risk for all of this, and so that's why it can be very tough to get out of these. When you have a bad thing like this going on in a family system, it's not necessarily the exact same problems as the parents, but it does make you more vulnerable to problems. So other long-term effects, all of this, kind of the self-mutilation, like a real feeling of hatred toward themselves, um, inability to, and when we say inability to protect oneself, what we mean is the person that grew up with this kind of childhood, they don't realize what is really out of bounds. When usually a relationship that becomes violent, it's not all at once. It happens where the abusive person kind of cuts you off from your other support system. They'll say they're jealous. They don't want you hanging out with your friends, and they kind of isolate you a little bit at a time. So it's for somebody that didn't grow up in that, you realize that's happening, and you stop it. You either end the relationship or you stop that happening in the relationship. But if you don't know that that's not abnormal, then that's how you can fall into it. So that's and be attracted to the same kind of person. We have this tendency in our life to want to correct the things that went wrong in our childhood, with our life, with our living our life. And so, if you grew up in that kind of dysfunction, it can put you at a risk to have relationships and try to work out your feelings about your childhood through your own relationships that are not healthy. All right, so a big part of what we have to focus on as professionals, healthcare professionals, is how to report the violence and the abuse when we see it. And so some of the big things here, you'll see our little forms. They're in the module, the child abuse reporting form. Actually, you'll hear it called a SCAR, and what that stands for is Suspected Child Abuse Report. There's also there's an Adult Protective Services report as well that you'll find in the module, and then there's something called an ombudsman, which we'll talk about in a second. But anyway, first of all, one thing to realize is you don't need proof. You are just reporting things that are suspicious. It's the job of the other agencies to investigate. So what you do is you don't want to put any of your opinions in. You want to keep it all observations. Quotes by the patient, or victim is very helpful when you have quotes. So you can put their quotes in, and their quotes might be subjective, but they are their quotes. And so those are good to include. Injuries and any kind of treatment they needed for those injuries, and any kind of referrals made and follow-up care. But yeah, the quotes are really important. So one of the things you'll find out with all of these agencies, especially Child Protective Services and Adult Protective Services, these these agencies are overwhelmed, and so when you make reports, they've, you know, there's a tendency if there's any way they can convince you not to make a report, they'll try to do that sometimes. Um, Now, what I was told when I did my last Child Protective Services report or SCAR that I filed, um, that if the person that abused the child is not in a caregiving role and doesn't live in the household, then it's it is more accurate to report it directly to the police. Um, that's not what my professional organization says for my MFT, and so I still report it to Child Protective Services. Now they say they report it to the police when it's not somebody that's in a caregiving role for the victim. Um, but I do what my profession tells me to do. And they can do what they want. Adult Protective Services, if they're over 65 or if they're disabled, if they're a dependent adult, and by dependent we mean disabled. We don't mean just like financially dependent. We mean adults that are have a cerebral palsy or something like that. They're on disability, and so that's Adult Protective Services. And then an ombudsman. There's a county ombudsman where if somebody is living outside the home, if they're in a program like a nursing home, board and care, um, those kind of settings, that's you report it to the ombudsman. Now these reporting responsibilities, these can lead to you losing your license. That's why you'll notice in the module I forget exactly what it's titled, but I put in, it's actually an advertisement for a law firm that specializes in suing healthcare professionals that didn't make their, fulfill their reporting obligations. And so the reason I put that in there is just to impress on you that, how important it is that you make these reports and you make them within the time that we're going to talk about on the next slide. And that there's actually lawyers out there that specialize in suing you if you don't fulfill these requirements. All right, so basically what happens is if you have a patient that tells you something like this, um, you'll make a call to the agency, the correct agency, and then you're required to send the written report within 2 working days. You don't want to wait till the next day. What you want to do is, call the report as soon as possible, because what you want to do is, especially if you're not working day shift, if you're working an off shift, sometimes the people take a long time calling you back. Generally in the evening time and on the night shift, you'll call and you'll get an answering service, and they have to like page the on-call, usually social worker, child welfare worker, or adult protective person. They have to page them, and the person's at home, and they call you back. And so sometimes that can take hours. You don't want to wait till the end of your shift to make that report, and then you'll be stuck there overtime because someone else can't really report what you got firsthand. It has to be you. You can't pass that off to the next shift. Now, if they take a long time and you do have to leave, that you just chart that in the, document that. But you don't want to document that you called at the last minute and then had to leave because your shift was over. Yeah, and then basically the way it works these days, we used to have to mail it, but now you just, you'll get the fax number and you'll fax the SCAR, the suspected child abuse report or adult protective services report. And another thing that's important for that as well is, when you send the fax, you want to make sure your fax machine has the confirmation that it it was received by the the organization. And so you want to get that printout from the fax machine that says it was received, because then you have proof that you fulfilled your responsibility. If that agency is disorganized and they somehow lose the form and claim they never got it, you want to have proof that it, you sent it correctly, you sent it to the number that they gave you, and it was received. All right, so here's some basics for elders. So elder abuse, remember you reported to the ombudsman, and this is where you can find it for Contra Costa County. That's where you can find Adult Protective Services. For domestic violence, there's going to be a hospital procedure. There's a lot of different ways to go about it, but you do have to talk to the patient by themselves. And it's not just patients that come in with suspicious injuries. You have to ask all patients. As part of your admission protocol, you always have to ask about abuse, regardless of what they came in for. And that's just one of our requirements. And you have to, document their answers. If you have, you have to talk to the patient alone to do that. So if you have a situation where you do have a spouse that doesn't want to leave, and you can't ask in front of the spouse or caregiver, anything like that, or parent. So what generally they do in ERs, from what I hear, is they'll come and they'll say they have to take the person for an X-ray or something like that, and then once they get the patient away from the spouse or caregiver, then they ask the patient the abuse questions. And so that's just one way if you have that kind of situation, to get around it without having to, because really you have to call security and get into a power struggle with the family member. And remember from the earlier part of this PowerPoint that families where there's violence going on, that they have poor boundaries. They are not going to, and they don't want the person they're victimizing to be interviewed by themselves. They want to be able to monitor the information that goes out. All right. And so if they do have injuries, you do a body map, and you probably remember from your anatomy class, the body map, it'll actually be in your whatever Epic or whatever electronic health record system your hospital uses. And it'll be that kind of man where he's standing with his palms forward, and there's the figure is facing you, and then each side, and then you see the figure from behind, and you just document on that figure where the injuries are. If there is that's what a body map is. If for some reason your Epic doesn't have that, you just have to be very detailed where the injuries are. You also are gonna, you need to photograph the injuries if the patient gives you permission. Anytime, regardless of the cause of the injury, you always want to try to photograph any injuries that the patient comes in for, because you want to, first of all, you need to show that it didn't happen under your care, but also you've probably heard the phrase, a picture is worth 1,000 words. It's especially true when you're trying to press charges for domestic violence. There's a famous case from years ago, like, I don't know, 6, 7 years ago. There was a football player named Ray Rice in the National Football League, the NFL, and he had gotten arrested for being violent with his fiance. And so it came out, the NFL reviewed it all, and they suspended him for 2 games. But then somehow it happened in an elevator, and there was actually a surveillance video from that elevator. And when the surveillance video came out and hit the news, it was so dramatic. It was so brutal what he did that the NFL suspended him for a year, and no other team would ever re-sign him. So his career was over. Um, and it's very emotional to see the abuse happen, to see someone, a man, especially a large man, hit somebody like that, and just the way he treated her. That you know when you see these kind of photos, it really strikes you how brutal it was. You can remember the photos that I showed you earlier in this PowerPoint, that a description of what's in those photos wouldn't even compare to the emotional reaction that actually seeing the photos has. And so it's always best to take photos, even if the person doesn't, if they don't want to press charges, they might want to press charges later. All right, so workplace violence for nurses. Well, I'll probably show you a video on this, that, in one of our skills labs where there's some nurses that get attacked by a patient. Um, like in psych, we can't do that because of confidentiality, but there's one that's out there on YouTube. Anyway, sometimes it's like you go in your job, and your job is to deal with patients that are agitated, and you can't always get away. And so, every once in a while, if you work in a really acute setting, if you work in the emergency department, or if you work in psychiatry, um, you're there's a good chance you're gonna have at least some kind of violence happen to you. Um, it is considered a felony, and California passed a law saying it's a felony for any kind of assault on the emergency department staff. Um, what I've found in psychiatry, it's hard to get the police to file charges, because they'll say, oh, the person's not in their right mind. And usually they're right. Sometimes we do get patients that they kind of feel like they can be violent because they're in a psych hospital. But most of the time it is because they're paranoid or psychotic or detoxing, or whatever it was that led them to need to be hospitalized. And so um, it is common for healthcare professionals to get PTSD. Um, there's actually a YouTube group, or not YouTube, I'm sorry, Facebook group that has a specialty of healthcare professionals that have been subject to a lot of violence. Um, I used to belong to that Facebook group, but it was too much. It's kind of like I know the reality of what's possible out there, but I don't want to see it all the time. Um, but anyway, yeah. So let's see. So anyway, getting a little mixed up where I want to go with that. But it's never part of your job to be assaulted. Now, it is something that might happen, and it's not okay when it happens. And that's why we have the trainings for those of you in the psychiatric nursing rotations. That's why you'll have a training with me, how to get away when someone is trying to attack you. It's not common for patients to try to attack student nurses, because you're not the ones that are telling them no, or generally you're not the ones setting limits for the most part. But it is possible, and it's there's a reason why we all have to have this training once a year if you work in psych, or if you work in an emergency department. And so sexual harassment can lead to sexual assault. So any kind of flirty comments by a patient, you never want to just let that lie. You always want to confront them and say that's inappropriate. Um, all right, so a 76-year-old male is admitted for surgery. The nurse notes that he's not wearing his hearing aid or glasses and that he has many bruises on his hands, trunk, and arms. The nurse will A, ask him about his platelet count, B, consider that he left his glasses and hearing aid at home due to surgery, C, make a report to Adult Protective Services, D, call his family to bring in his glasses and hearing aid. So I'm going to go ahead and go over these answers. If you want more time to think about it, just go ahead and pause this video. But A, ask him about his platelet count. That's a patient is not going to know that. B, consider that he left his glasses and hearing aid at home due to the surgery. Well, that's possible, but you need to ask him that. So you would want to interview this patient without a caregiver present. It is possible that he may have left his glasses at home. Maybe in the past he came in for surgery and they lost his belongings, and so he didn't want to worry about that, but you'd want to ask him that. You wouldn't want to make a report to Adult Protective Services because you don't know that yet. You don't have enough information, but you would if he did tell you that the bruises on his hands and his trunk and arms were, if they were caused by his caregiver. And you would only call his family to bring in glasses and hearing aid if the patient wanted you to do that. So this question has no clear answer. It's one of the reasons I like it, because it makes you think for a little while. And don't worry, the questions on the exam will be more clear than this, although they won't be super clear because they're nursing questions. But yeah. All right, so your assessment, first of all, you want to make sure you're aware about your beliefs and your well, let me just say, and when you have these kind of questions where you can go back and look at your own beliefs about something or your own self-awareness, that's almost always the correct answer on nursing exams and on the NCLEX, because they want to make sure that you look kind of look inside and make sure you're not making assumptions based on your history, that you want to have that kind of awareness. And that it is important that you kind of know, and you've looked at things, and you don't have kind of an unconscious bias toward either certain groups of people or certain races or sexual orientations or gender, whatever. You want to always have an awareness of any kind of possible bias you might have. And so that's just something to be aware of. Pay attention to how the family communicates. Does one person dominate? Those are important. Is there poverty going on? Is there drug use? And is there just a lot of stress in the family with these kind of issues? Unemployment, especially for men, because part of our self-image is being productive in the work world. That's something that for men can cause a lot of feelings of powerlessness, especially for men, for women also, but and especially if you don't have money, and there's a lot of short-term consequences. All right, so indications of abuse: the person's anxious, passive, partner does all the talking and is possessive and controlling. So that's another thing. Remember, you got to separate them and interview the patient without the partner present, and look for all the places. Remember at the start of this PowerPoint, all the places that that are really rare to have an accidental injury. you know, all the places that don't come in contact when you bump into things or fall down. All right, so you're going to ask about these things. Like I said earlier, it's required by the law that we ask all of our patients about abuse. You don't have to lead with that, but you do have to get to it. And like you see with the bottom here. So I put this in bold. This was before we had electronic health record um, at my job at Herrick. This was the actual exact quote we were supposed to ask the patients. Um, and so that's something, if you can't think of how to phrase the question, that's a good one to look at. So for the perpetrator, you're usually not in the situation to assess the perpetrator, but if you are, um, these are good questions to ask, determining how serious it was. And it depends on what role you are. If the perpetrator is your patient, sometimes especially if you work in psychiatry, you'll have a patient that, this happened a few times when I worked on a unit that specialized in substance abuse. And so people, when they get clean, sometimes they'll have a lot of guilt around the things they did when they're intoxicated. And so the things that they tell you, if they tell you that they've abused somebody, you have to report it. Now, what I've done in the past when that happens is I'll have I'll call the Child Protective Services or whatever type of report we need to make. I'll call them and have the patient, or that's the perpetrator, with me, and the perpetrator can actually make the report. And that kind of makes it where they feel a little less guilty. They're starting to take responsibility, and it also makes it harder for them to deny it later on if they go back to their substance abusing and they have disclosure remorse and they deny that they ever told you about it. Okay, so anger management treatment, you make that information available. We'll talk in a moment that the most important thing for people that have been violent is to recognize triggers, and the most effective treatment for abusers is, abusers that are violent is group therapy it's usually court mandated. And when I worked for the organization, it's now called STAND, but it used to be called Battered Women's Alternatives. I did an internship with them for my MFT license in 1994-95, and in the men's program, the men that actually showed up for the groups and went through it was kind of like a psychoeducational thing, but there was a lot of talk about their feelings too. And almost all of them had been referred by the court mandated. The ones that completed our program, it was something like 98% would never be arrested again. And so that was a very effective program. I believe it's still intact. And now it's called STAND, like I said, all in capital letters, kind of short for Stand Against Violence. All right, so some other symptoms to watch for: somatic complaints that are chronic. Especially there's a lot of cultures that tend to somaticize their psychiatric complaints, which we'll talk about when we'll have a lecture where we talk about somatic disorders toward the end of the semester. But a lot of, especially if they're poorly educated, or if they're from a culture that doesn't really embrace psychiatric problems, so depression, anxiety, sometimes the elder is protective of abusers because they want to be able to stay in their house. They know if they, if the abuser is somebody that's, like son or daughter or something like that, that if they disclose, they might, and they lose that person as a caregiver, they might not be able to stay in their house. Um, Sometimes they're over medicated. They'll have like a diaper rash or something from being left alone. Um, Socially isolated because the person that's abusive is trying to, doesn't want them to tell people. Or they might be under medicated, especially with cardiac medications. It's kind of like the caregiver doesn't want them to live long, so they either consciously or unconsciously they don't give them the medications that'll help them, that help them like live another 5 years or so. The ones that they're usually over medicated by things like sedating medications because the caregiver wants them to go to sleep and they don't want to deal with them. All right, so there always is a risk of homicide when in these domestic violence relationships. Um, some of the one of the things that happened when I was with Stand, we had a policy. One of the things that happens in relationships, where kind of the classic where the man is the abuser, the woman's the victim, and the woman leaves them. But if they have kids, frequently the father does have some custody rights. And so there's always a dangerous time when they're changing, there's the handoff of the kids. And so at Stand, we had a policy or kind of a recommendation to our patients that you always do the handoff of the kids in a public place, usually a parking lot, kind of close to where the people are in the parking lot, not like at the ends, and you never go alone. And so we had a situation where a woman with her two kids, she would habitually bring her mom with her, and they would meet like in the parking lot of a convenience store, like a 7-Eleven. And during one of the times, the husband, he came and he had a gun and he shot the wife in front of the two kids and the mom in public. And so it was very traumatic for the whole organization because, that's what this woman had done what we told them to do. She had followed the our recommendation and she still was murdered. And so that was it was hard. It made us have to look at what we recommend. And still, I think the recommendation is basically still the same. It's hard. Um, I mean, some variation could be you don't always have to, it doesn't have to be you handing off the kids, you know, and whenever possible, you want to have it where, if the person, if it really is documented, all of this abuse, hopefully there can be either where the abuser has only supervised visitation, where there's a court officer or somebody there that's supervising the visit, um, or just not having the visitation rights because probably they're really not safe to be alone with the kids anyway. Um, so yeah, there's always this risk of homicide, um, and there's frequently threats of homicide. When when I worked for when I was the intern at the domestic violence agency, um, one of the things one of my responsibilities is I worked the crisis lines, and this was in the year after the O.J. Simpson, Nicole Simpson Brown, where Nicole Simpson Brown was murdered along with a young man that was bringing her sunglasses from a restaurant. And O.J. Simpson, if you don't know who that is, he was a professional football player in the 70s, and then a movie star and a broadcaster of football games, and celebrity, a very famous person, Heisman Trophy winner in college, if you know what that means. Um, and somebody just big in the culture as well, very famous. And he was accused of showing up and murdering them both. They were found murdered, and it was a big thing in the culture at the time. So what I would find on the crisis lines is there's a lot of these relationships. The man would try to terrorize a woman by saying, "I'm going to do an OJ on you. I'm going to go OJ on you." Um, and so really there's that kind of threat of a homicide is always there. And and you know, like I said earlier, there's not one type of abuser, but generally people that are abusers, they do want to intimidate, and they do use whatever they can to intimidate their victim. All right, so include the patient in all decisions. It's a really important thing because the person already has a sense of not having control. So you really want to make sure that they have a feeling of control. So you want to have them create the plan with your guidance. Um, and a safety plan, it's a little easier than when I worked in domestic violence because back then, this is how old I am, there was no internet, so you couldn't have electronic copies of things. Um, but now you can have that, like passports and drivers, all that kind of thing, you can have electronic copies of. But really you had to have, what's been termed like and this is what's been termed a bug out bag, which is what survivalists, these people that like live in the woods and think that society is going to end and you have to survive. But for the victim of domestic violence, it really is literally, you have to have things together so that if something happens and your life is in danger, you can just grab this one bag and be gone. You don't have time to go look for things. And so the kind of things you need in that is first of all, some money, um, whatever you need in the short term, change of clothes, like I have here, your prescription meds and prescription meds of your children, if you're taking children with you. Um, you know, you do still need a passport. That's one of the weird documents in our culture where you can't just get by with a copy of. Um, but yeah, in a plan, and what are you going to do if it happens again, and it's really bad, and you're about to get beat severely, and you may even be murdered, and so you have to encourage the patient to develop a realistic plan, and then they have to find a way to have this the bag that they're going to have, the bug out bag, to they're going to have it somewhere where the abuser's not going to find it, and so they need to put some thought into that. All right, so you'll treat their injuries, assess, is there a chance the person's going to come for them wherever you are? If you're at an outpatient clinic, is it possible they may have gotten followed? Is there a car parked out in front? Um, are the children in danger? Are the children, at school where the father might, the abuser might go and abduct them to kind of hold them against the mom? Um, One of the things that makes it hard for a woman that's being abused or a person being abused, I keep saying woman, and it usually is a woman, but it's not always. Anyway, what makes it hard is you can't always go to a domestic violence shelter. One of the requirements to be able to go to a shelter is you can't you can't go anywhere during the day where the abuser knows you're going to go and then return to the shelter, because the shelter, first of all, they have to protect themselves and the other, the other domestic violence victims in the shelter. And so if you're at a job where the abuser knows you're going to be there, or if you're at a school where the abuser knows you're going to be there, you have to quit that job and drop out of school. And so, you can't, like I said, you can't be somewhere where the abuser knows they're going to be, because they can't take a risk that the abuser is going to follow them back and be violent at the shelter. So that's a lot of the reason why. I'll give you a case example from a case my wife told me about. My wife, the ER social worker, she had a patient who she was getting abused, and she was in an LVN program, licensed vocational nurse program, and she had like 4 or 5 months to go. And it was a really bad case. There's a law where if you're living in the household with a person that is being violent with you, you can get what's called a kick-out order, which is a temporary restraining order. And if you're living in the same household, that person has to leave. And so you do it. It is only temporary. I think you have like 30 days. It has to be renewed. And so anyway, this patient that was in the LVN school, she got that order, and her abuser had to leave. And it was really a nasty case. They had come here. He was some kind of professional. They came here from Africa, and he got some kind of high-paying professional position. And she didn't have a career. That's why she was going to LVN school. And so anyway, she got the kick-out order, and he came back when she wasn't there and got the locks changed and took out all of the furniture. And she was pregnant. She was pretty far along, like 6 months or so. He stole her prenatal vitamins even. And so this was really an abusive, vindictive person. She was, he had the heat turned off and the electricity turned off, so she's sleeping on the floor, pregnant. She had, was able to get like some little, like a sleeping bag to sleep on. And still, she didn't want to go to a shelter. She knew, like, long term, what she really needed was a profession that paid decent, so she could be on her own and be independent. And she did succeed. She finished her LVN, and she got as far as we're aware. One of the things also, unless patients come back when you work in acute care, you don't see them again. And so you assume she's doing okay. All right, so like I said earlier, you'll always photograph injuries. You do have to ask the patient permission, but generally that's not a problem. And some just basic things that you probably already thought of is if you're taking a photo of somebody's private areas, you do try to keep their face out of it, but you do want to make it obvious that it's them. So you might want to have a picture where they're wearing the same clothes in the same situation that does have their face in it, so nobody can say it's not them. But you do want to, and patients generally they comply with that. All right. So prevention of elder abuse. So we want to train caregivers in anger management, and don't, sometimes this is very basic. It's not something that's that involved. Just managing their expectations of what the person's going to be able to do. Um, if you have if they're taking care of a patient that, especially if they have something where they have dementia, and one of the dementias where they strike out and they can be violent sometimes, that can trigger somebody with an anger issue. Um, if they have sundowning, um, you also have to train your caregivers. Probably the biggest problem with something like skilled nursing facility staff is in programs, and I've seen it in hospitals, where it's so hard to get good staff on the night shift that sometimes you can get abusive night shift people and nobody's really there to see it. There's not like supervisors there. Depending on the type of program it is, they might be the only actual RN. Um, and so, they're kind of like the boss, and so nobody wants to challenge them. Um, and sometimes it's really more kind of an abusal, it's emotional abuse. Um, so anyway, trying to train them how a big thing, like I said, is to help them manage expectations of the patient, what's normal, help them not take things serious, so personally when a patient is acting out, or just doing the kind of things somebody does when they sundown, like running around, peeing on the floor. If I can use an example from from my mom, who had a little sundowning toward the end of her life. Um, yeah, so that's the big one. So basics with other things. Remember, for people that are abusive, like I said earlier, the big thing is group therapy, focusing on anger management, identifying triggers, what can be their plan when they're triggered. You know, some people like count to 10 or count down from 10. Um, One of the things that I found when I was a couple therapist was, if you know couples get in a dynamic where there's a thing going on, and the person that can have an anger problem isn't as good. Usually the man isn't as good at expressing himself verbally, and so gets overwhelmed, and then breaks stuff, or whatever. So what really has to happen, and then the female might have abandonment issues, and so the male like storms out because they can't handle it. A common problem is the female following him, still yelling at him. Um, and so one of the things that I would train couples that have this kind of dynamic going on is the the man would say, or try to say, I'm not leaving you. I'm just need a break from this, and I'm gonna come back in 30 minutes, and we'll talk about it. And so, trying to say that so that the person knows they're not being abandoned, the relationship's not over. Um, they just need to get away from it. And so the person with the abandonment issues can usually handle that. Um, and so that's just one of those little kind of interventions that you can use. All right, so developing coping skills for both. All of these are good for coping skills, and these are good for coping skills for any kind of situation. You need to develop coping skills. For children, now, there's high risk parents that come from these situations where they grew up with a lot of ACE things happening in their childhood. Um, Sometimes, especially with teenage mothers and fathers, the parents really do need to learn how to, first of all, kind of like with the older people, what's normal for a baby. The baby is not crying at night to bother you. The baby's crying at night because that's what babies do sometimes. Um, so you role model how to communicate with infants, like, making the eye contact, and how to soothe the baby is probably the best thing that you need to role model. Um, I'll just tell you another little story. When I was younger, I used to commute to Cal State East Bay in Hayward by BART, the BART train system. And I remember this one young teenage boy, I assume he was teenage, he was like, he looked to me like 16, 17, 18. Anyway, he had a baby with him, and the baby wouldn't stop crying. And he started, this baby was, like 3 or 4 months old. So this baby wouldn't stop crying, so he got frustrated with it, and he started slapping it on the head. And um, and it was interesting because all of the all of the women on the train kind of converged on him, yelling at him to stop. You can't slap a baby like that. And it was very, it was interesting to me because, you could see him, he was getting defensive, saying, "Oh, well, it's my baby, I can do what I want," which kind of shows you how the boundaries are a problem with people with violence issues. But also, to me, it looked like just a kid that had no idea how to manage a baby at all, and kind of got defensive with the people yelling at him. But my guess is the message got through to him that is not okay to do, and and you know what you would want to do as a nurse is, once the little crisis was over, you want to teach them what to do with the baby that's crying like crazy. Um, don't one of the things we don't babies don't come with a manual. It'd be really great if they did. Anyway, so other interventions, you can refer them to these programs. They all have help. Children's Hospital in Oakland, also you'll hear it called CHO for CHO. The Smart Healthy Babies program, I believe, is still there. The program at UCSF, and then San Francisco General. And when the victims and witnesses to violence, there's actually it's either federal or state, I'm not sure, but there's something that's called the Victim Witness Program, where victims where it's actually somebody's been documented, they've been a victim of violence, and it's formally accepted. It's like it's already been adjudicated. It's happened. Um, they're eligible for funds that cover their therapy. And when I was a therapist working in a private practice, those were the patients you always wanted because from a billing point of view, the government would pay your full fee, and they would pay it without a bunch of managed care mumbo jumbo, where you have to send reports back and forth and get pre-authorized for a couple sessions at a time, and all this kind of thing that made private practice really a challenge in the 90s. So anyway, there's things available for them. All right, a nurse is scheduled to lead an anger management group for abusive people. Which of the following are appropriate goals? Select all that apply. A, participants will identify triggers to anger. B, the participants will no longer feel anger. C, participants will have increased self-esteem. D, participants will count to 10 when they feel angry. And so again, if you want to contemplate this, pause the video, but what I'm going to tell you is all of these answers are correct. So prevention, well, we want to try to foster self-esteem in all people and assertiveness. All of these. I'm not going to go point by point, but this one, power differential in couple relationships where usually the male has all the power, just like that the case I referred to with the LVN. These kind of fundamentalist or especially extreme religious beliefs that kind of isolate the family from the rest of the culture, and then unrealistic expectations. And so some of that can come across as, I mean, sometimes parents think they can really control their kids in a way that, you're not going to date before you're 18, all those kind of things. Well, that's 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 going to be a challenge, and that's going to be frustrating. And so sometimes you have to work with parents around their expectations around that kind of thing. All right, in the clinical setting, um, when you have patients that are most violent, um, I'll skip down to the bottom here. The ones that have head trauma, um, they can be the most impulsively violent people that you'll ever see. And especially if there's trauma to the temporal lobe, um, those people are very, very assaultive. Other patients that can be very, very violent, well, first of all, just a basic thing, anybody with a history of violence is much more likely to be violent in the future. Um, Violence is not a normal thing to be. It's not normal to be violent. And so anytime somebody has a history of something that's abnormal like that, they're much more likely to have a future of it as well. And so a patient with a history of violence is your top priority and something that you should write on in your notes. Um, and then, along with head trauma and then a history of being abused themselves, um, some other things that are on here that I'll go into a little more detail. So, of course, agitated and paranoid patients um, that are delusional, patients that are manic can be very impulsive and violent. Um, Substance abusing patients that are either intoxicated, especially if they're intoxicated with something like PCP, and we'll go into it a little more in the substance abuse lecture, but with PCP, the thing that stands out is you'll see their eyes, they have a distinctive motion where they're kind of like looking side to side in a very strange way. That's a sign that they could be very violent. Um, Intoxicated on methamphetamine, um, cocaine as well, especially crack, and then withdrawal from these substances as well can make people very, very assaultive. Another one that's sometimes it's got a lot of attention lately, but sometimes not taken as seriously is withdrawal from nicotine. If they're a strong smoker, one of the things that you really need to do is make sure they have something to help them with their nicotine cravings. And that's actually it's on our violence assessment when I'm admitting a patient at Herrick. Are they in withdrawal from nicotine? Is one of the questions. All right, so we try to get them if they have if you're concerned that they're going to be violent, you want to have them you don't want them to be in a room where there's a lot of noise. You don't want them right next to the front door where they can hear it slam all the time. You try to acknowledge their feelings. We have what we call emergency medications, and so you'll have we talk about hacks and B-52s and what that you don't need to really memorize all that, but unless you work in psych or in emergency settings. But yeah, the hack is the Ativan, the Haldol Ativan Quinjetin. The B-52 is Benadryl, and then she's I think 5 of Haldol. I don't actually the B-52. I don't, and the 2 of Ativan. Yeah. Anyway, I'm not exactly sure. The B-52 we haven't used it that much, but it is the favorite of our new medical director, so I'll learn that better. And the doctors never just say B-52 unless they are absolutely sure you know what that means. And if you have any question, if a doctor does use that kind of terminology with you, always ask for clarification. Anyway, these are frequent emergency medications. Now, on this slide, I see Risperdal. Risperdal is the least effective of these ones we have on there. It doesn't have quite as much of a short-term effect as the other ones. Geodon is a medication that is an atypical antipsychotic that's used a lot, especially in settings where a patient might not have, you know, provided us with a good history. They might be low functioning and not a good historian. And so it's the atypical antipsychotic that's least likely to raise blood sugar. So if you think that there's any kind of possibility the patient has diabetes, that's the one doctors like to go with. Um, and if you remember from the legal lecture, we can give these medications in an emergency. We can give them against the patient's will if they're being dangerous and violent, but there can't be a routine order for emergency medications. All right, so like a timeout. Now, whenever I give somebody a timeout that's an adult, I never call it a timeout because then they're going to feel like they're being treated like a children. But I'll tell them to take some time in your room and calm down. And if they can do that, then I don't need to give them the emergency medications. But more of the time than not, you end up having to do that. But you do want to try to remember, we always want to try to do the least restrictive interventions, so we want to give them a chance. All right, and then physical restraint and seclusion. So remember, one of the things that I believe I mentioned in the legal lecture was the patient really needs to be able to follow commands and stay in control. And the way that staff frequently test this, especially if they're not in restraints, if they're just in seclusion, generally the patient is standing at the door when you're about to go in. And so you'll see the staff person, through the window, they'll say, "Have a seat on the bed." That's not, that's not, sounds pretty benign, but that's actually a real assessment question. You're testing them to see, can they follow a simple direction? And if they can't have a seat on the bed, if they're like too manic or too agitated, you don't go in. Because about 90% of our assaults on staff happen when trying to talk to a patient that's already in seclusion for being violent or assaultive. So if they can't even follow that command before you've even gone through the door, you don't go through the door. So anyway, the thing that I do to test patients to see if they can handle it once they've had a seat on the bed, or if they're in restraints, and that's not a question I can ask them, is I try to cause a little frustration. One of the things I'm trying to assess to see if they're going to be violent, if they're going to do the kind of violence that led to them being put in seclusion, I need to tolerate I need to see if they have frustration tolerance. And so I'm going to talk to them and assess them, but I'm also going to intentionally take a little longer and maybe be a little circumstantial myself and not get to the point. And what I'm looking for, can they tolerate that, or are they going to, are they trying to put a good face on because they want to get out of seclusion, but they're really not ready. And so what I'm trying to see, if I take a little longer to get to the point and everything, and I seem like, what I want to see, are they going to get upset and say, "Just let me out of seclusion"? Now, if they do that, then I can see they're not quite ready. So they've failed my test of frustration tolerance. But if they can stay with me and tolerate me kind of intentionally being slow about things, then I let them out. And I tend to let them out. I let them out as soon as I can. None of us want to keep people in seclusion that don't need to be there. And so it's always good to get them out. All right, so we went over this in the legal lecture, but just we try to take them when you take somebody out of seclusion and bring them back onto the unit. You want to do it at a time when there's, it's not a stressful time in the milieu. A frequent time, like if they went in before a meal, is to like give them the meal in seclusion and then bring them out after, because it's a less you know less stimuli on the unit. If they, especially if they have to join the other patients to eat a meal, that's more stimuli than you want for somebody that you're trying to introduce back to the unit gradually. All right, so when you document, you always want to document why they went into seclusion, all the less restrictive measures that you attempted, and that they didn't work. And you really want your documentation to show that it really was the last resort, that it wasn't that we didn't try other things. All right, so crisis communication, when a patient is about to become violent, when they pick up the chair over their head, and it's too late to say, hey, if you do that, we have to put you in seclusion. You're not going to be able to get discharged tomorrow, and all that kind of stuff. They can't process that. So what we've been trained to do and what works is you need to say their name and then just whatever the command is you want them to do. So like in my example where the patient picks up the chair, you say their name and then the command. Put the chair down. John, put the chair down. Don't throw the chair. Um, and, the name gets their attention, and then the command, you want that to be just direct. No extra words, no mention of consequences, nothing like that. You just want to give the direction. Now, this is when they're about to be violent. And so this isn't just a patient that's agitated or that you're worried is going to be violent. This is a patient, about to go from being agitated to actually committing a violent act. Okay. All right. So you're working with a patient who's pacing, raising her voice, and has clenched fists. Which interventions are most appropriate? A, decrease stimuli. B, offer the seclusion room. C, ask, you seem upset, tell me about it. D, increase the space between the nurse and the patient, between you and the patient. E, speak in a low, calm voice. And so this one, it doesn't say on the question, but treat it as a select all that apply. And if you want a chance to think about this, again, pause the recording because I'm going to go into it. So A, you do want to decrease stimuli if they are agitated like this. Remember clenched fists, that can be they're about to be violent. When you say offer the seclusion room, some settings have it where you can have the door open to seclusion. Like for those of you, if you're ever in a psych rotation at the county hospital in Martinez, their seclusion rooms in the psych emergency, they can have them unlocked and they can have them just in there with it unlocked. And so you can offer that to decrease the stimuli, in the what we call open seclusion. Other units, they don't have that capacity sometimes because you have to go through into a locked area to be in the seclusion room. Asking, you seem upset, can you tell me about it? That's definitely a correct answer. And so A is correct, B can be correct based on the facility you're in, C is correct, D is correct, but so you need to have the space between you and the patient. It has to be enough where the evasive maneuvers that I teach you that you can you can get away before the patient can assault you, but you also can't be, you're not going to be able to connect with the patient very well if you're, way down the hallway. And you do want to have a low, calm voice. Now, I know one of the handouts that I put in the module sometimes, it says you can't help an emotionally disturbed patient, if you're emotionally disturbed yourself. So you have to calm yourself down before you can help anyone else be calm. All right, so like I said earlier, one of the limitations of this 2.5 hour lecture is that there's not a lot of time for rape, which rape really could be its own lecture. Um, it's very it's one of those things that is almost always severely traumatic and frequently can lead to post-traumatic stress disorder. Um, when in the acute phase, 2 to 3 weeks after, it's common that the person is in shock, they feel numb, and they really just want to forget that it happened. They don't want to accept it. They don't want to think about it. And so, um, if you talk to a patient that's in this, sometimes I've heard staff think they don't believe it. Why is the person not more upset? But it's because they're numb. And what happens when you try not to deal with it and you just try to push it out of your mind, that might work for a little while, but it's going to come back. Usually your psyche needs to process it, and so it'll come back in nightmares and intrusive thoughts, and you'll think about it. Um, these behaviors here that are normal for the long-term reorganization phase, which we talked about after 3 weeks, is, if it happened, wherever it happened, making changes there. So like if it happened in your house or apartment, not wanting to stay there anymore, at least not by yourself. Um, and moving, changing your phone number if that was somebody that was an acquaintance. All right, so sex trafficking is, like I mentioned earlier, the Bay Area is it's famous for our child prostitution area in the Oakland airport area. Um, there's also sex trafficking through kind of Asian massage parlors, and there's a whole Russian organized crime thing going on as well. Um, so yeah, we think of slavery as a shameful time in our country's history that is long ago, but it's happening, right under our noses, right here. And so, that's something we're trying to, in sex trafficking. One of the things with sex trafficking, there's like a little business card that people that come across sex trafficking victims, they'll make a business card that has the sex trafficking phone number, hotline number on it, but you can't have that on the card, because if the sex traffickers find it, the person is in very grave danger of being beaten and murdered. And so, they put it on something that looks like a hairdresser or something like that, or some kind of hair salon, something that hopefully wouldn't arouse suspicion if the traffickers found it on the person of the person being trafficked. Um, it's very different when you have somebody that you suspect is being sex trafficked. You can't just call the police and get them involved, because that can lead to the person being trafficked getting murdered. Um, it's not like a domestic violence situation where the person being arrested will never do it again, or probably won't do it again. These are organized crime, and this is a much different situation, and so it has to be handled a lot differently. Um, most of the time, your sex trafficked person, what I'm told by people that see this in emergency rooms is, it'll usually be there's some man that brings them to the ER for some kind of care, and the person will describe them as an uncle or something like that, and the person that's watching them, that's with them, is very controlling. All right, so when you get a patient and the patient tells you that they've just been the victim of rape, What your responsibility is, you have to send them to whatever emergency room in your county has what we call a SART team, which stands for Sexual Assault Response Team. That's a California term. It has a different name that's very similar in other states, but in California it's called Sexual Assault Response Team. Um, in Alameda County, it's Highland. It's at Highland. At Contra Costa County, it's at Contra Costa Regional, and Marin County, it's at Marin General. And what these are, the Sexual Assault Response Team, it's made up of people that are specially trained to handle somebody that's just been raped. And that's the ER doctor that does the rape kit. That'll include usually the nurse involved in it. It'll involve contacting usually the local rape crisis center to try to have somebody from that organization come and make a connection with the patient, and also how to support the patient in filing a police report. And so frequently, like I said, they're in that first stage after the person's been raped. They just want it to go away. They don't want to press charges, but part of the focus is collecting evidence and getting photographs and things so that if they want to press charges in the future, they have that option. And like I said earlier, if you have photographs and you have evidence, DNA evidence and everything, your case is a lot stronger. What's really important is we don't re-traumatize the patient when they come in. That they feel supported. They don't feel like they feel believed, and the people there are sensitive and they're not in a hurry. They're really trying to help them. I do have the SART manual from 2016 in the module for this lecture, and so as far as I'm aware, that's the most recent one that's available on the internet. And that basically goes into all the details if you're interested in being part of a SART team when you go out there as a nurse. If you work in an ER, you can maybe have that option if you're interested. But the manual, that's a good thing to review if you want to look at that further. All right, so we have these crisis lines. RAIN is a big one, and that link does work. Community Violence Solutions. This organization, it used to be called Rape Crisis, but it's kind of expanded a little more. And it is, you see the San Pablo address, it is very, very local to us at Contra Costa College. And it has all of these. It's always important. I referenced the patient that got the kick-out order, got the temporary restraining order. Frequently, these patients, they need legal help, and so they can help them connect with. It's usually people that are studying to be lawyers that help them. All right, and then we have the place where I did one of my internships as a marriage and family therapist, and then a national domestic violence hotline. All right, so a patient has started on Depakote for repeated poor impulse control and aggression toward her family. And in planning to address her aggression and promote coping, the nurse will A, suggest that she meditate to become calm, B, ask her to identify triggers to her violence, C, tell her to take her Depakote when she's angry, D, make plans to start family therapy. So again, if you want to contemplate this, pause this video, So A suggests you meditate to be calm. Meditation is a very effective way to help people with aggression, but it is very hard. It's not something you could really I mean, you can suggest it, but um, it's not easy. If you've ever tried to meditate, it takes a while to get good at that. Um, B is definitely a good one. Identify triggers to our violence. Um, C would not be effective. Remember, Depakote has to be a certain level before it's helpful with managing people with an elevated mood. And then D, and I don't think I have it as part of this presentation, but you don't do family therapy with somebody that might be violent with their family because that can lead to violence. You might meet with the family without the person that can be violent to help them deal with it. But really, you don't want to trigger a violent episode. So until their anger is under control, you wouldn't want to do family therapy. All right. The next quiz question. The nurse is assigned to work with a perpetrator of sexual violence. In planning care, the nurse will consider, select all that apply. A, the perpetrator is a victim of sexual abuse. B, recommending incarceration. C, never be in the same room with the patient. D, having a security guard be stationed on the unit. And E, the perpetrator came from a violent family. So again, if you want to think about this for a minute, pause your video. So looking at A, yes, so the perpetrator could be a victim of sexual violence, sexual abuse. Part of the way people work through it when they've been sexually abused, one of the dysfunctional things is to be an abuser themselves. That's kind of how we process things by living our life. Especially if you don't get therapy or have insight or anything. B, recommending incarceration is really not your role. You're not able to send your patients to jail. Never be in the same room with a patient is not an option. You can't care for your patient without ever being in the same room. Now, if your patient is very dangerous, you can make sure you're never, first of all, if they have given you any kind of clinical justification, you can have them restrained. You can have them on a one-to-one where they have a one-to-one staff. And like what D says, you can ask if a security guard can be stationed on the unit, which is good because your responsibility isn't to just protect them, to protect yourself from the patient. You have to be worried that patient might victimize other people on the unit, other patients and other staff. And then E, the perpetrator came from a violent family. So that's very possible. I don't know, part when you answer these kind of questions, you want to look at what is the question actually asking. And so when you look here in planning care, the nurse will consider. So planning care, I don't know that the perpetrator came from a violent family is really helpful when it comes to planning care. Along the same lines, A, the perpetrator is the victim of sexual abuse. So when you're planning care, that would only be helpful if you were going to refer the patient to, if they were a sexual abuse victim, that you might refer to them to therapy to process that. All right. All right, we are at the end of this presentation. I do have a lot of helpful things that I've put in the module for this lecture. And if you have any questions, please send me a text or send me an email. Text is probably better because like the rest of the culture, I spend too much time looking at my phone. I don't always respond right away, especially if you're asking a complicated question. So sometimes I will take time to think about it, but I will get back to you. Now, if it's something that, if you're in one of my student text groups, please, unless it's something personal about yourself or somebody in your life, send it to the group text. And, usually somebody in the group text might also have that same question. So anyway, thank you very much. I know this was a tough presentation. I know that it's hard to see a lot of the stuff and talk about this and learn about it. Um, and I know, statistically speaking, that that some of you have been victims of these type of issues. Some of you have been, abused. Some of you have witnessed violence between your loved ones. Some of you have, maybe even been raped or something. And so this can bring up a lot of feelings. If you have any problems like that, please let me know. And also, if you're not comfortable letting me know, if you want to keep things personal, just remember I do have in the syllabus, I have listed the ways that you can reach out for psychological support if you need it. So look at the syllabus for that. We went over that the first day. All right, so take care, everyone. And just remember, our mission is as helping professionals is to protect people, and that's our first priority is to help our patient, and if they're in a dangerous situation, see it and help them get out.